urinary system. Anyone?
It's essential in filtering the blood.
Okay, good. So I'll begin with some of the functions of kidney. As we all know, kidney has an endocrine function. It has also activation of vitamin K. It also has gluconeogenesis when there's prolonged fastings. But as for now, I'll begin with the anatomy of the kidney straight. But the urinary system consists of the kidney, which are here, and then the ureter, the urinary bladder, and the urethra. Yeah. Here. So from here, from the anatomy of the kidney, the kidney first is a bean shaped structurally, and then it lies in behind the peritoneum, that's retroperitoneal, and then it has it's the basic unit of urine formation. Specifically, the nephron has that work. But I'll begin with the layers of the kidney. The outermost layer, there is a renal capsule. It's a loose connective tissue. It's just, I don't know if you can see the, wait, I don't know how to do these things, but here, just before the renal cortex, there is a layer that's called the renal capsule. It's made up of loose connective tissue. Mainly, its function is to protect the kidney from infectious microorganisms to enter into the kidney. And underneath, there's a layer of fats that's called perineal fat capsule. It's like an adipose tissue. The fatty capsule, it's like the adipose tissue. So it helps to nourish the kidney. So under that, Sasa, it's the cortex. Before the cortex, actually, there is the renal fascia, which is a connective tissue that actually surrounds the structure, and it keeps it to the peritoneum. It keeps it to the peritoneum since it's behind the peritoneum. And then right here, wait, let me show you a very good diagram. I had another one. Why is it marking things? Sorry. Yeah. This diagram, it shows like everything I was explaining. The outermost layer that I said, it's the renal capsule, which is a loose connective tissue, and then it follows by the fatty adipose tissue, and then there's the renal fascia, and then after that there is a hole which is here in between the renal vein and the renal artery. It's not the renal pelvis, but it's called renal healers. It's a hole where the arteries and the different the arteries and go in. That's what it's called. And then it's also different from the renal sinus, because the renal sinus, it consists of the renal pelvis, which is like this area. Let me try to mark it again. Yeah. This place is the renal pelvis, But before the renal pelvis, there's an outer inlet that lets the renal vein and the renal artery inside it. So that's basically, and then the major parts of the kidney is three parts. The renal cortex, which is this outermost layer, the renal medulla, that's pyramidal shaped, and the renal pelvis, so the third one. And I'll go straight to the innervation, the blood flow. So the blood comes from the aorta to the renal artery. It comes to the renal artery. It enters through the hole that I was mentioning, and then it first goes to the first, like here. It goes to this pyramidals, the first of them. The blood goes there before it goes to anywhere else. This is the renal artery. As you can see, it traces. It goes to the renal pelvis, which um, which actually forms the renal papilla. Like when you add all these pyramids, they all form the papilla. So the blood innervation to it, it's through a tube that's called the minor calyx. And then all the minor calyx will form together and form the major calyx, which sasa all of them will form the the renal pelvis. Am I making sense? Do you guys understand that? Hey guys, do you guys
Yes.
understand?
Yes.
So when they form the renal pelvis, that's how its innervation starts from. So the renal artery, when it reaches to the kidney, it subdivides to segmental artery, which goes to the inner lobular artery. This is the inner lobular artery it's showing here. It's the one that sasa innervates the specific pyramids of the minor calyx and the major calyx. And then um, each and every lobe is surrounded by cortical tissue. The cortical tissue and the whole of together with the pyramid, this pyramid, together with like the whole of it, like each and every pyramid is innervated by acute artery, which is a branch of inner, it's a branch of interior lobular artery. This acute artery will then subdivide to enter to the renal cortex. When it enters the renal cortex, it's sasa the cortical radiate artery. That's the one will innervate to the outer side of the pyramid, the outer side of the kidney. Let me show you a nice picture here. Okay, let's just use this one. From the outer abdominal aorta, it goes to the renal artery. The renal artery, the moment it enters, it subdivides to segment artery. And then the segment artery will form a branch, that's the interior lobar artery, that will innervate the pyramid that I was explaining. And then each and every lobe, together with the connective tissue, is innervated by acute artery. The acute artery will divide to form the cortical artery. And then the cortical artery is the one that goes to the afferent artery in the Bowman's capsule. And then the opposite happens in the venous. The opposite is when it goes to the afferent, it then comes out from the efferent arteriole, then it goes to the peritubular capillaries. This vasa recta it's actually connective tissues that form concentrated urine. They are beneath the efferent arterioles in the medulla. That's what the vasa recta are. So the efferent arterioles will feed whatever that's it's collected from the capillaries of the glomerulus to the peritubular capillaries. And then it goes to the cortical radiate vein, to acute vein, interlobal vein, to renal vein, back to the inferior vena cava. That's pretty much the blood supply to the kidney. Are we guys together, or I repeat it?
Shafi, kindly repeat.
Okay.
Shafi, one question. You say there is a particular artery that innervates the major and minor calyxes and the pelvis. Could you please also repeat that point? Thank you.
Okay. The specific artery that innervates the major and the minor calyx is the interlobular artery. Since when the renal artery, the moment it enters the kidney, it forms the first branch, which is segmental artery. Segmental artery is a major branch, but this interlobal artery, it goes inside the renal cortex to the renal pyramid and innervates the major and the minor. So together, everything from the major and the minor, they are all innervated by the acute artery. Everything, like it moves onwards as we progress, because here we are beginning from the innermost layer going upwards.
Okay,
So
thank you.
the cortex is the outermost layer, right? And the medulla is the innermost layer. So the medulla, it has pyramidal shape. Every pyramidal shape, each and every pyramidal shape, it's called a minor calyx. So when it forms everything together collectively, it's called the major calyx of the renal pelvis. So it's all innervated by interlobular artery. Are we together?
Yeah, thank you.
So let me repeat the blood flow again. From the abdominal aorta, it enters through the hole that I mentioned, the renal healers. Through that hole, it's inside Sasa, the renal pelvis. When it's inside the renal pelvis, it subdivides. The first segment it subdivides, it's called the segmental artery. The segmental artery is the big artery that it goes to the pelvis and re-innervate each and every pyramid through the interlobular artery. Interlobular artery is specific to each and every minor calyx, and then collectively everything it will synapse, and then like it's collectively it will form the acute artery, so which will move to the what do you call it, forms like the acute artery branch. It's a branch. I don't know, I'm getting confused at this point. The acute artery, it branches to form the cortical radiant artery, which will go to the afferent arterioles in the Bowman's capsule. Since like the goal of all this blood supply is it's coming from the aorta to the kidneys. This is how it all flows from the aorta to the renal artery. The interlobal supplies blood around the renal pelvis, and then the renal pelvis, it will move to the inner parts, so the inner part of the renal pelvis, which will move to the Bowman's capsule. That's when it will join the afferent arterioles. Then the efferent arterioles into the glomerulus. Then through that, it will go to the efferent arterioles to form the venous blood circulation to be out of the kidney. Are you guys understanding?
Very, very much, Shafi.
Because this anatomy it's not anatomy, but I'm trying to explain as much as I can. So if you're okay with this blood flow, I'll go directly to the nephron, the kidney nephron. So the nephron is the structural and functional unit of the urine, which forms the urine. It's the structural and functional unit of the kidney. And then the volume of urine that's formed in 24 hours is about 1 to 1.8 liters of urine is produced in 1 hour. So there are two parts of the nephron, the renal corpuscle and then the renal tubule. The renal corpuscle, it forms the glomerulus together with the Bowman's capsule. And the renal tubule is the Bowman's capsule together with the PVT, the whole nephron, from the pelvic, from the proximal convoluted tubule to the ascending loop of Henle, descending loop of Henle, everything. That's when it forms the tubule. And then the actual kidney nephron is the Bowman's capsule and the PCT, loop of Henle, and DCT. Those are the nephron. The glomerulus and the Bowman's capsule, they are called renal corpusculars. Yeah, the renal corpusculars. This one. Sasa. Yeah. So I will start using the notes of Dr. Hermes since I want to explain some other things. Is my screen visible?
Extremely, extremely.
Like never before.
Yeah. Yeah. So the nephron, as I've said, it's the renal tubule. It's the most significant structure of the kidneys that contributes to the formation of the urine. So let me start from here, from the Bowman's capsule. Inside the Bowman's capsule, there's glomerulus. After the blood enters here, these glomerulus are capillaries. So it filters the blood out and then it goes to the Bowman's capsule. The Bowman's capsule, it's where the reabsorption of sodium and water occurs. And 66% of sodium is reabsorbed here. And of sodium is reabsorbed in water. And there's also some reabsorption of carbonate and glucose. And then as we go to the descending loop of Henle, actually this whole nephron thingy, it works with transports, passive transports of water from according to osmolarity of the surrounding cells. That's how it works. Like the water is going outside to the tissues according to you get the difference in osmotic pressure. So in the loop of Henle, there's passive transport of water through the medullary osmolarity. Then as we go down to the ascending loop of Henle, this is where the reabsorption of 20% of sodium occurs. And then as we go upward, we go to the descending loop of Henle. Also, there is a reabsorption of water. sodium carbonate, and there's secretion of potassium. And then the whole concept of this nephron thing, all these structures, they have ions, electrolytes, which contribute to the urine concentration level. So this is why different drugs act on different sites of the nephron. And then we have to remember three things when we're dealing with urine formation. The glomerular filtration, which is the movement of substance from the blood within the glomerulus into the capsular space. The second one is the tubular reabsorption, which is the movement of substance from the tubular fluid back into the blood. The third one is tubular secretion, which is the movement of substance from the blood into the tubular fluid. All this, it will contribute to the amount of concentration of urine that you're going to have. So because the whole essence of the kidney, its functions is to lower the blood volume. How does it lower the blood volume? Changing the concentrations of electrolytes inside the kidney. Are we together?
Yes, please.
Okay. Serafina, do you guys want me to explain a bit of pharmacology of everything the transporters, Ama? We move regardless.
I think here we do not move irregardless. Yeah.
You contribute, so each and everyone contribute. What do you guys think?
Yeah. At this point, especially so as to gain a good understanding of the diuretics, we just so we start with the proximal convoluted tubule, look at the transporters there, and then we cover the carbonic anhydrase inhibitors. When we go to the thick ascending loop, we look at the physiology, and then we cover loop diuretics. Yeah, so that when we are getting to clinical pharmacy, it's just a breeze.
Okay, I'll ask questions.
That was my idea. I don't know if Divya is of a different opinion. She's always in the opposition nowadays.
Am I? No, that's okay. That's all
okay,
right.
I'll ask questions from here, and then I'll stop sharing my screen. Okay?
Yeah, we're all friends here.
Okay, the whole thing disappeared. Wow. What is going on? Yeah. Okay. Sorry for that. I was struggling with the laptop. Okay. In the proximal convoluted tubule, there is sodium hydrogen exchanger. And then in the proximal PCT, 40% of the sodium in water is absorbed. So how does this sodium I mean, sodium and hydrogen antipode, how does it work? Anyone? Guys?
Yeah, I think we can display just a diagram of the transporters found on the proximal convoluted tubule to help with understanding, so that I think it will be better that way. Just an image of the. Let me see. I think I can display if your laptop is acting up.
Yeah, it was acting up.
Has it stopped?
I was struggling with it. I don't know if you guys can see if I share the diagram.
We can see your screen.
Here, can you see this one?
Yeah. This one, yeah.
Okay. Oh. So let me try explaining how this antipode works. So in the PCT, the free energy of sodium gradient from the basolateral side. This is the basolateral side here, the lumen side. So the sodium is pumped by this antipodes inside the lumen membrane. It's pumped into the lumen membrane, and then when it pumps sodium in, it takes out hydrogen out. So the hydrogen that goes out, as you can see here, it reacts with bicarbonates to form sodium hydrogen carbonate here. Can you guys see my cursor moving? Am I stopped in one place?
We can see it moving. We can see your cursor moving.
Oh, yeah. When it forms the hydrogen carbonate, it will the hydrogen carbonate then decomposes to carbon dioxide and water. And water, in the presence of this enzyme, you can see right here, carbonic anhydrase, it goes back to the it goes from this membrane here inside the PCT, so the actual PCT, through this border, it goes back. So the CO.
Sorry, did you just say the carbonic anhydrase takes the water in? Or does it facilitate the hydrogen carbonate to break into water and CO2?
Yeah, but seawater it's in the presence of this carbonic anhydrase, it breaks water to CO2.
Okay. Thank you.
Yeah, you're right. It breaks water to CO2. And then the reaction between water and carbonic and carbon dioxide is low. But when you use carbonic anhydrase, it accelerates the reaction. Yeah. That's where that's how it works. Like when the sodium goes in, wait a minute. Wow, guys, I don't know why this screen is removing itself. Can you guys see my screen?
No.
At this point, this laptop is disturbing me. Someone else share, please, if you have the notes of Dr. Ermias. I don't have that diagram in my phone. I could have shared it in the group and then someone else could have shared, but let me just continue.
Can you see this?
Yeah.
Yeah, we can see.
Yeah.
You can use this to explain.
Okay. So I said in the lumen, there is hydrogen ions, which react with carbonic HCO2 to form bicarbonate. Then the bicarbonate is decomposed to carbon dioxide and water, bicarbonic anhydrous. But it can this process takes place, but it's slowly when carbonic anhydrous is not there, since the gradient of sodium, concentration of sodium, is higher on outside than in the basolateral side. So it's pumped into to the inside of the PCT by the antiporter. So when it's inside, it will exchange hydrogen. So the hydrogen that's outside, it can combine. It reacts with the bicarbonate to form to form the bicarbonate. It reacts with the HCO2 to form the bicarbonate. So this process is slow, and it's faster with carbonic anhydrous um, enzyme. So the slow proton concentration in the cell will lead to ionization of carbonic anhydrous spontaneously to form hydrogen and bicarbonates. So that's how it creates the electrochemical gradients in the basolateral membrane. Yeah, I don't know. Can you see my cursor? Here. Is it visible?
Yeah.
So
I think they can see my cursor moving.
yeah, because I'm trying to show something and then I cannot. I don't know. But let me just explain. So the electrochemical gradient that forms from the bicarbonate, it's used by sodium hydrogen carbonate symporter that's in the basolateral membrane to transport bicarbonate to interstitial cells, Sasa. To to that space. So the net effect of this sodium hydrogen carbonate symporter from the tubular lumen to the interstitial space leads to the movement of water and its reabsorption. So after the water is removed, the concentration of chloride in the lumen diffuses also through concentration gradients into the interstitial space. That's how I can explain, unless someone else has another explanation to explain it.
And also in the PCT, if there is any glucose uh or amino acids, they are also absorbed in the PCT.
Yeah, it forms almost 65% of sodium reabsorption and 100% of glucose and amino acids is reabsorbed in the PCT. So when you detect glucose and in the blood, that's one of the determinants that shows the function of the glomerular filtration rate. It's an indicator of glomerular filtration rate, which means there's no way a glucose can be found in the urine. 100% of it is reabsorbed in the PCT. So what carbonic anhydrase inhibitors do, they inhibit the enzyme carbonic anhydrase. So there is no
Shafi.
Yes, guys.
Well, I heard you calling my name. I was on a call. What's up?
Explain this Nini. How does it work? Explain.
Stanley has refused to explain.
Yes.
Let me even kick him out of the meeting.
Uongo, hata hujaniita Shafi.
Okay. So there's this now my cursor can't be seen, but there's the basolateral side, and this other side is usually called what? The basolateral is the side in touch with the blood. The other side is called
That's the
the
luminal
luminal
side.
side. The luminal side.
yeah, luminal. Yeah, luminal. Yeah, luminal side. Yeah. So we have the basolateral side and the luminal side. So everything will begin in the blood, or rather on the basolateral side, whereby we know in all cells we have this sodium potassium ATPase. The sodium potassium ATPase, yeah. So with the sodium potassium ATPase, we know it pumps sodium out and potassium in. Yeah. So on this, alas, who can remember?
Guys, I think you're breaking.
Okay, I can just try. For
Right.
so as you started with that, we have the sodium potassium ATPase channel. Yeah. So for every potassium that is pumped into the proximal convoluted tubule, 2 molecules of sodium will be pumped into the blood. Yeah. And then we'll be having the hydrogen ions and the carbonate ions. So that on the luminal side, we have the sodium hydrogen pump. Yeah. So it's going to pump the hydrogen to the luminal side and pump that sodium inside. Okay. So when the hydrogen is pumped to the luminal side, it's going to combine with the carbonate ions that are outside and form bicarbonate ions. And we have carbonic anhydrase enzyme that is going to break down the bicarbonate into water and carbon dioxide. The carbon dioxide then moves to the cell and will combine with water with the same enzyme, carbonic anhydrase, to form bicarbonate, and the cycle repeats.
Yeah. Are you guys understanding that? What Trina just said? Because when we now use the carbonic anhydrase inhibitors, they'll inhibit the conversion of bicarbonate to water and carbon dioxide. So there will be more C2HO3 in the luminal side. There will be accumulation of bicarbonates in the lumen, since there's no hydrogen in the cell that can exchange for sodium. Are we together?
Yes.
So we move to the descending part of the nephron. In the descending parts, it doesn't have the same sodium potassium ATPase. So it does not have active sodium reabsorption, does not happen in that site. What's happened instead is
Wait, do you want me to change the slide?
hmm?
Do you want
Do
me
you
to
have a
change the
slide?
slide?
Do you have a slide that can show the proximal?
One second, yeah, let me find it. Is it? Would this work?
I can't see it.
Okay, can you see my screen or no?
I can't see me anything. I don't know if anyone can see. Can you guys see?
Yeah. It's
Wait.
maybe
You want me to stop sharing?
Hi guys, I got disconnected. Can you see my screen?
Yeah.
Yes.
Okay. So we were saying.
Very clear, very clear.
So this is big ascending. Yeah, here we have the proximal convoluted tubule. Yeah. So we were saying that the magic starts on the basolateral side with this sodium potassium ATPase. I don't know if someone answered for how many sodiums are pumped out and how many potassiums are pumped in by the sodium potassium ATPase. You need homework. How many sodiums out, how many potassiums in? Anyway, this is where it starts.
3 sodiums out, 1 potassium in. Or is it 2?
Yeah, 3 2. Yeah. 3 sodiums out, 2 potassiums in. So 3 sodiums out, 2 potassiums in. Yeah, nice. So no homework. Yeah. So the sodium potassium ATPase, we know the principal function, it's pumping sodium out of the cell and potassium in. But now in the case of the tubules, in the case of the kidney, I just want you to remember that it pumps sodium out, okay? It pumps sodium out of this proximal convoluted tubule cell. It pumps sodium out into the blood. That means that it creates a gradient, or rather, inside of this proximal convoluted tubule, there'll be less sodium. Inside of the cell, there'll be less sodium. So it creates a gradient for sodium to move from the lumen side, that is from the urine, into the proximal convoluted tubule. Yeah. So, and that gradient is what will be used for absorption of some of this stuff. So let's start with now the absorption of bicarbonate, where even the carbonic anhydrase inhibitors will work. So absorption of bicarbonate, we start with this transporter. It's pumping sodium, it's pulling sodium in and pumping hydrogen ions out. What kind of transporter was this called? It's one is being taken in and one is being taken out.
Antipode.
Antipode? Yeah.
Yeah, nice. Antipode. One in, one out. But this one we'll see, this one is a sympod. They're all moving in the same direction. So this antipode, sodium in, hydrogen out. Remember that sodium moving in, it's by the gradient created by the sodium potassium ATPase. So sodium in, hydrogen out. Now hydrogen is out. Hydrogen in your urine, you have your bicarbonate. So, and once hydrogen and bicarbonate see each other, they'll always associate, even in the absence of the carbonic anhydrase. In the absence of carbonic anhydrase. Carbonic anhydrase acts between two levels, or between two compounds. That is the carbonic acid and the water and CO2. That's where it acts, between this carbonic acid and water and CO2. But when the ions are by themselves, the ions will always interact, and the carbonic acid can always dissociate without the action of carbonic anhydrase. So once the hydrogen has been pumped out, it has associated with its good friend, the bicarbonate. It has formed the carbonic acid. Carbonic acid, by the action of now carbonic anhydrase, which is found on this luminal side, it will split it into water and carbon dioxide. Water and carbon dioxide. So water can diffuse through carbon dioxide, can also diffuse through, right? Because remember here we've absorbed sodium using the sodium hydrogen antibond. That means, and we already say wherever sodium goes, water will follow. So water will follow, carbon dioxide will diffuse. Then once now water and carbon dioxide are inside the cell, again, by the action of carbonic anhydrase, we are able to obtain our carbonic acid. Then we said carbonic acid can spontaneously dissociate. It spontaneously dissociates into a hydrogen ion and a bicarbonate ion. That hydrogen ion and a bicarbonate ion. So dissociation into that, we now on the basolateral side, the bicarbonate and the sodium, these are that sodium bicarbonate symbol that will now transport bicarbonate and sodium into the blood. So that is how we are able to absorb bicarbonate. Okay. It started with the sodium potassium ATPase. It established a gradient. That gradient led to sodium absorption and hydrogen excretion. Hydrogen associated with bicarbonate to form carbonic acid, which was dissociated by the action of carbonic anhydrase to H2O and CO2. CO2 and H2O diffused into the cell. Again, by the action of carbonic anhydrase now inside the cell, we obtain our carbonic acid once again. From the carbonic acid, it dissociated and generated our bicarbonate and hydrogen ion. The bicarbonate went into the blood, the hydrogen ion went into the urine, so as to lead to absorption of most stuff. Yeah. Hadi hapo, are we good? Are we good?
Yes.
Yes.
Okay. Now, and then just one other thing that deserves to be mentioned here, because we'll be looking at diabetes. Also in the proximal convoluted tubule is where we have this sodium glucose dependent transporter, where again, due to the gradient set by the sodium potassium ATPase, this is a symbol that will absorb sodium and glucose. Sodium on one side, glucose on the other side, leading to absorption of glucose or reabsorption of glucose into the blood. Yeah. So the sodium glucose, the SGLT2 inhibitors will be working here, leading to glucose being lost in urine, and we'll see what side effects that can cause. But just for the proximal convoluted tubule, also remember that your SGLT2 transporters are here. But now let's go to the focus. The focus today is here. Now, we've seen the work that carbonic anhydrase is doing to absorb bicarbonate. So once we have our drugs, carbonic anhydrase inhibitors, the acetazolamide, they come and inhibit this carbonic anhydrase. They inhibit this carbonic anhydrase, they inhibit this carbonic anhydrase. Now, what do we expect? Once we've inhibited this carbonic anhydrase, what do we expect? Do we expect more bicarbonate reabsorption or less bicarbonate reabsorption?
Less.
Yeah, nice. Less bicarbonate reabsorption, because we've inhibited that, the kind of the mechanism that leads to a bicarbonate reabsorption. So if we are not absorbing bicarbonate, as a side effect, do we expect to see acidosis or alkalosis?
Is it
There's accumulation of carbonic acid.
Wait, when the bicarbonate is less reabsorbed less,
Yeah.
doesn't that lead to alkalosis? No, wait.
Acidosis.
Acidosis, yeah.
Yeah, exactly. Now in that case, it will lead to acidosis because we are losing our bicarbonate. You know, bicarbonate is there too. Bicarbonate is alkali. We are losing bicarbonate. So if we are losing bicarbonate, acidosis definitely comes in as a side effect. Yeah. So for the carbonic anhydrase inhibitors on their mechanism of action, that is it. Unless someone has something to add on carbonic anhydrase inhibitors. Nothing, okay. So examples of carbonic anhydrase inhibitors, you should be able to sing them. What are some examples of carbonic anhydrase inhibitors?
Acetazolamide.
Acetazolamide, Anyone else apart from acetazolamide? Pardon?
Metazolamide.
Amesema methazolamide.
Yeah.
Yeah, metazolamide. Yeah, nice. Yeah. So that's it for the proximal convoluted tubule. The major thing there is absorption of bicarbonate and also absorption of glucose. So next, I don't. Someone else can now take us through the loop of Henle.
Guys.
Yeah.
Guys, there was agents that were used for carbonic anhydrase inhibitors. I think it's dozolamide.
For glaucoma.
Yeah.
Yeah, dozolamide. Yeah.
I wanted to, but I don't know. It's mechanism of action. This one, acetazolamide. It will just lower the what do we call it in glaucoma? That pressure that's elevated. It will lower that because it will inhibit the carbonic anhydrase, and then kind of, but I'm not conversant with the mechanism of action, but
yeah, it reduces the production. Yeah, by inhibiting carbonic anhydrase, it just reduces production.
Please take us through the next one. I'm tired now.
Acetazolamide is also used for altitude sickness.
What?
Acetazolamide is also used for altitude sickness.
So yeah, the altitude sickness, yeah, or the acute mountain sickness. Then so from the proximal convoluted tubule, we know it will go down, and then we'll have our loop of Henle. Now, at the loop of Henle, yesterday when we saw the question that asked which one is the most potent diuretic, and the answer was the furosemide because it acts on the loop of Henle or on the thick ascending loop. Because now this thick ascending limb, the thick ascending limb or the loop of Henle, this is where a lot of the absorption we'll see occurring here, because the thick ascending limb has a tremendous absorptivity capacity, right? Yeah. So at the loop of Henle, this is where a lot of absorption occurs here. That's why the loop diuretics are the most potent diuretics out there. If you give someone acetazolamide, they may not be peeing that much. If you give someone hydrochlorothiazide, still not as much. But if you give someone furosemide, that person will be going for short calls every now and then, because the thick ascending loop is a very major site of absorption. So the thick ascending loop here, there's again, you'll always notice the sodium potassium ATPase is at the center of this thing. Sodium potassium ATPase establishes a gradient where sodium is deficient inside the cell. So for these transporters, you see the ones that act through passive, or rather that do not require energy, they are driven by the sodium gradient. Because sodium is low inside the cell, sodium just wants to flow in. Yeah. So in the loop of Henle, we have this major, or rather, we have this one transporter that deserves to be mentioned, that we'll also discuss. And this is this NKCC2 or NK2CC. It absorbs sodium, it absorbs potassium, it absorbs chloride. You can imagine absorption of all these things. We are seeing absorption of sodium, absorption of chloride. That means even the water that is being absorbed at this level is a lot of water, right? So for the thick ascending loop, it doesn't have much explanation wise like the proximal convoluted tibial. Yeah, so here we just have this transporter that will transport sodium, it will transport potassium, and it will transport the chloride. Again, this is a sympot. And for the loop diuretics, they are usually called high ceiling diuretics. High ceiling diuretics. Why are they called high ceiling diuretics? It's because after you've passed the thick ascending limb or the loop of Henle, after you've passed this stage, absorption that occurs after the thick ascending limb is usually just minimal absorption. So this is the main place, hence the term high ceiling diuretics. Okay. Yeah. So unless someone has something to add on loop diuretics, but they just inhibit this NK2CC or NKCC2. Once they've inhibited that, sodium won't be reabsorbed, potassium won't be reabsorbed, chloride won't be reabsorbed. They'll also create, there'll be an electrical gradient that will be disturbed, also affecting the absorption of magnesium, the absorption of calcium. Hence, and with loop diuretics, we see a lot of hyponatremia, hypocalcemia, hypochloremia, hypomagnesemia. Everything is hypo. The only thing that goes hyper is hyperuricemia. So on this, maybe someone can give a few examples of loop diuretics, apart from furosemide. We've mentioned furosemide a lot.
There's bumetanide.
Yeah, bumetanide, torsemide, yeah. So
Ethacrylic acid.
Yeah, ethacrylic acid. How is ethacrylic acid unique from all the others, furosemide, bumetanide? What's unique about ethacrylic acid?
It doesn't have the sulfur moiety.
Yeah, exactly. Yeah, it doesn't have a sulfur moiety. Yeah, nice. Then now let's go to the side effects. For carbonic anhydrase majorly is that distortion of body pH. Yeah. Now for the loop diuretics, we'll see a lot of the hypo. We already mentioned hypo electrolytes. The electrolytes will be low. Of course, there'll also be an aspect of hypotension because you're losing a lot of fluids. So hypotension can come in. Yeah. And the other thing that can occur now with loop diuretics.
Also metabolic alkalosis. There's an
Yeah,
increase.
metabolic alkalosis. Yeah, nice.
And then
Because when
there was a side effect that it brings with COX-2. I don't remember that. NSAIDs inhibit salt transport. I don't know how they do it, but it induces two furosemide together with NSAIDs. It is COX expression of COX-2. I don't know how. I Google it. Yeah, they prevent prostaglandin mediated, so they increase the wait.
They reduce the renal blood flow, which like this loop diuretics are supposed to do. But when you give them with NSAIDs, they reduce like that renal blood flow because NSAIDs inhibit prostaglandin inhibition synthesis.
They don't reduce, they increase the renal.
Yeah, sorry, increase, yeah.
Yeah, because it will inhibit the symporter, sodium, potassium too. They will inhibit the symporter.
So are we saying, so what effects do
Okay.
NSAIDs have on renal blood flow, especially on the afferent and efferent?
They'll increase renal blood flow.
They'll increase.
Yeah. It's like they have like a vasodilator effect by increasing prostaglandins and the COX enzymes. So, but when you give them with NSAIDs now, that's like a drug interaction because NSAIDs reduce prostaglandins or they inhibit the COX.
With the diuretic effect of loop diuretics, and then by so they will ultimately increase the renal blood flow.
Wait, just to take you back, NSAIDs, I thought prostaglandins, especially on the kidney, prostaglandins work to vasodilate the afferent arterioles. So once NSAIDs inhibit prostaglandin formation, they'll impair that afferent arterial perfusion, which can lead to the acute kidney injury. Do NSAIDs increase renal blood flow or decrease through the action on prostaglandins? Just a question, because in AKI, we will mention that they do decrease renal blood flow by inhibiting prostaglandin synthesis.
So I think then it will reduce because if you're saying it works to...
What you're saying is different from what you're saying. The mechanism of action for prostaglandins to increase blood flow together with loop different from what you mentioned. What you mentioned, it will decrease the renal blood flow. But this one, the mechanism of action is unknown. That's why the NSAIDs are not given totally with diuretics, with loop diuretics especially. Instead of decreasing the renal blood flow, which means they attenuate the diuretic response.
Yeah. Now, yeah, NSAIDs generally they reduce the efficacy of diuretics in general, because by decreasing afferent arterial blood flow, it means we are decreasing the amount of blood available to undergo ultrafiltration. Hence, we are decreasing even the urine available. Yeah. So yeah, NSAIDs generally they decrease the diuretic response, any type of diuretics. Yeah, that's why even as a side effect of NSAIDs, we'll see water retention. So for patients with heart failure, NSAIDs is a big, it's something to give with a lot of caution.
So you guys were saying that the NSAIDs will increase or reduce the renal blood.
They'll reduce because they will impair the dilation, prostaglandin mediated dilation of afferent arterioles.
Yeah, that's correct.
Yeah. Thank you, Professor, for putting the tick. So we were mentioning the side effects of loop diuretics. We've seen the hypo, we've seen the alkalosis. Now, the other thing that is unique and that will lead to a lot of interactions is ototoxicity, right? Loop diuretics cause ototoxicity. Which class of antibiotics cause ototoxicity? Anyone who can remember? Hence, will not be administered with these things.
Aminoglycosides.
Aminoglycosides, yes. Nice. The other thing we already said can cause hyperuricemia. But we'll see this as a side effect of a lot of diuretics because it's a compensation by the body. That once the body notices, hey, I'm losing a lot of water, the body just increases its absorptive capacity. And that will include absorption of uric acid. Okay. Yeah. Then the other thing is the hyperglycemia that we see with the loop diuretics and even with the thiazide diuretics, that hyperglycemia will be there. Increase in the LDL cholesterol may also be present. Yeah. So as something to mention is aminoglycosides definitely contraindicated with the loop diuretics because of that ototoxicity. Yeah. Unless
there was an also autotoxicity was induced. I don't remember. Like, I think it's cisplatin.
Yeah. Cisplatin and carboplatin. Yeah.
How does it?
No, they are also, even them, they are ototoxic.
Oh.
So yeah. So we can move to the distal convoluted tubule. Kosawa. Hi. Now to the distal convoluted tubule. In the distal convoluted tubule here, we are seeing the absorption of three key things. Number one being sodium, number two being chloride, and number three being calcium. So number one is sodium, number two is chloride, and number three is calcium. So those are the three key things that will be absorbed from the distal convoluted tubule. So let's see. Again, story as well as time. Sodium potassium ATPase sets the gradient. You know, sodium potassium ATPase is always the one setting the scene. Sets the scene by creating a sodium gradient such that sodium will want to move from the lumen to the cell, right? So that's the story. And then there's this symport here. When sodium is getting in, chloride it will hitch a ride and also get in, right? So we've absorbed sodium and chloride, right? Now let's go to calcium. For calcium, that we'll have to explain it pole. Now we've absorbed sodium, right? We absorbed sodium, so we are having a lot of sodium inside this cell. A lot of sodium inside of this cell. Our sodium is plus, yes, plus. We're having a lot of sodium inside here because we've just absorbed it. This is, we've not given any diuretic yet, right? We're having a lot of sodium inside of this cell. So because we are having a lot of sodium inside of this cell, and we are seeing here, there's a sodium-calcium exchanger. There's a sodium-calcium exchanger. Because we already have a lot of sodium inside of this cell, this sodium-calcium exchanger will now, in this case, I'll mention that some books mention that it stops working, and the other books mention that it starts working in reverse. In that calcium starts getting in, sodium starts getting out. In short, let's say this sodium-calcium exchanger reduces its function. So less sodium gets in, less calcium gets out, because we are having a lot of sodium inside the cell already. So there is no need for sodium to get in. We are having already a lot of sodium. So that's in a good situation. We have not given any diuretic yet. So no diuretic yet. Now let's work. We've given a diuretic inside of this cell, right? We've given a diuretic. What will the diuretic do? We've given our hydrochlorothiazide. We've given our chlorthalidone. These are the thiazide diuretics. They come and they've inhibited this, right? They've inhibited that. Once this is inhibited, it means there is less sodium inside of this cell, right? The sodium levels go down. Why? Because number one, we are not absorbing sodium because we've inhibited this channel here. And number two, the sodium potassium ATPase is still pumping sodium out. That means the sodium concentration inside of this cell, it goes down, Once it goes down, the sodium-calcium exchanger senses this change and it starts pumping more sodium in. Because it's like, this sodium is nowhere to be found. In the urine, we are losing sodium. In the blood, the sodium potassium ATPase is pumping sodium out. So there is no sodium inside of this cell. So the sodium-calcium exchanger to the rescue. It starts pushing more sodium inside of this cell. However, the sodium-calcium exchanger, it's an antipode, right? When it's pushing sodium inside of this cell, what does it mean? It means it's pushing calcium out. It's pushing a lot of calcium out. It's an exchanger. It exchanges the sodium for calcium. It's pushing calcium out. So what the thiazide diuretics will create is a situation whereby now the calcium levels inside of this cell, they are low. The calcium levels inside of these cells will now be low because the sodium-calcium exchanger has overworked. It's pushed a lot of calcium out. And now for the thiazide, now for the distal convoluted tubule, there's this channel here. The calcium levels are low, and there's a lot of calcium in urine. There's a lot of calcium just hanging there in urine. So what happens? The calcium will now diffuse into this cell. instead of being lost in urine, we'll see the calcium just wants to get in. The calcium wants to get in. Once the calcium is getting in, now that is why we'll say thiazide diuretics are unique in that they cause hypercalcemia because of that mechanism that we mentioned here. The calcium will get in. Another thing to mention about this channel is that this channel can be stimulated, or it can be more expressed by the action of the parathyroid hormone. Remember, parathyroid hormone always has a role to do with calcium and vitamin D. So when the parathyroid hormone is a lot, it also expresses, it stimulates expression of this channel more, and we're able to absorb more calcium. Sijui kaa tuko pamoja. Have we understood why diuretics cause, thiazide diuretic cause hypercalcemia?
Yeah, somehow.
Okay.
Mi sijashika, rudia tena one last time.
Aya, na mfollow. Hii ni story refu. Aya, let's start at the beginning. We'll start with the normal, and then we'll go now when we've given thiazide diuretics. Okay, so let's start with the normal. The normal one is there's this channel here, sodium chloride symport, right? We've not given this person any diuretic. So once there's sodium chloride in the urine, because of the gradient set by the sodium potassium ATPase, we are able to absorb sodium and we're able to absorb chloride ions. So hadi hapo we are together. This is a normal situation. We've absorbed sodium and we've absorbed chloride ions. So once we've absorbed sodium ions and we've absorbed chloride ions, that means now we are just following sodium. The chloride ions, they are not in this story. Now we'll just be following sodium. So we've absorbed sodium. That means sodium concentration inside of this cell goes up. The sodium concentration goes up. When the sodium concentration goes up, what this exchanger here is doing, the exchanger is pushing into the cell sodium and pumping out calcium. What the exchanger will do once it will sense that the sodium levels are already high, it will stop its work of pushing sodium into the cell, right? It will stop that work because this cell already has enough sodium. It will stop that work. So, yeah, and that is it. That is in a normal situation. You've absorbed sodium. Sodium has built up inside of your cell. The sodium calcium exchanger stops its work of pumping sodium into this cell. So that's normal. That's physiology. Now let's go to pharmacology. Pharmacology, now we've given this person a thiazide diuretic, right? The thiazide diuretic has come and it has blocked off this channel. It has blocked off this channel. If we've blocked off this channel, that means sodium is not going in, chloride is not going in. But again, I said we are focusing our discussion on sodium. When we've blocked this channel, sodium is not going in, right? If sodium is not going in, and we have this sodium potassium ATPase pumping the little sodium that is already inside of this cell out, what will happen? We'll create another gradient, a gradient where we have very low sodium levels, right? We'll have very low sodium levels. Why are there low sodium levels? Because sodium is not going in from the urine because we've blocked off this channel, and the sodium ATPase is not sleeping, it's still pumping sodium out. It's still pumping sodium out. So we'll create a situation whereby sodium is low inside of this cell. Now, because the sodium is low inside of this cell, the sodium calcium exchanger kicks into action, right? Sodium calcium exchanger, it's the hero. It's the hero of this distal convoluted tubule. Once you follow it, you'll be able to understand thiazide diuretics and hypercalcemia. So because sodium is low inside of this cell, the sodium calcium exchanger starts overworking. How is it overworking? It's pumping more sodium into this distal convoluted tubule cell. It's pumping more and more sodium into this cell. Once it's doing that, this is an exchanger. For every sodium it pumps in, it's also pumping out calcium. It's also pumping out calcium. It's pumping out calcium, right? It's pumping out calcium. Now, because it's pumping out calcium, already, okay, because it's pumping out calcium, even we can stop the story at there. Because it's pumping out more calcium, already we are creating a situation of hypercalcemia because it's pumping out more calcium into the blood. So we'll create a situation of hypercalcemia, right? But the story doesn't end there. But from that alone, you can be able to understand how thiazide diuretics have caused this hypercalcemia. But we've said the sodium calcium exchanger is pumping out more calcium. So it will create another situation, a second situation whereby the calcium inside of this cell is low. The calcium inside of this cell will now be low. And what can help the calcium inside of this level to go high? This channel here, there's a channel here for calcium. This calcium channel, now we will see a lot of calcium will move from the urine into this cell because we've created a gradient where inside of this cell, the calcium is low. So we'll see a lot of calcium move from the urine into this cell. We are having calcium now entering this cell. So by calcium entering the cell, we'll have less calcium lost in urine and more calcium reabsorbed because as it's entering this cell, it's still also being pumped out. Hence, we are having a situation of hypercalcemia. So that is how thiazide diuretics lead to hypercalcemia. I hope now we're all good.
Yeah.
So Janet, because this is the first time you've unmuted in 3 months. You take over. Now you're the one who will be looking at the collecting bills.
Amen. Somebody has to do it, please.
Someone else to do this part. We're having a lot of people. Bansri, Liz, Dr. Karemi.
Because if we zoom out, we see the full figure. I can see different from the ones that you're explaining. The sodium, potassium ATPase is not favoring the division of sodium into the epithelial cells, because I think in duct we are trying to avoid the sodium and the potassium excretion is both they're prevented. Am I right? Yes.
Yeah. People should unmute, please.
I don't know. People don't want to just assume that they're
Okay, so I think for the conducting ducts, we have the collecting tube, the principal cells, and the intercalated cells. Yeah. So here, on the blood side, we have this sodium potassium ATPase channel. That means that potassium will be flowing in, and I don't think there's much here, but just that the sodium that flows in from the urine side through the sodium channels will exit the blood via that sodium potassium ATPase channel, and the potassium that gets into the cell will move towards the ATPase. And here I think we have the potassium sparing diuretics that work on it. Oh yeah, and the aldosterone, the receptor, is it a receptor?
Yeah.
Yeah. So the aldosterone is going to stimulate the rate of sodium reabsorption and potassium secretion. And
yes, I think from the lumen where the urine is, since the sodium that's entering this epithelial sodium channel is entering into the cell, the principal cell, it creates a negative gradient here in the lumen. That's why the chloride ions are going into the blood. So when the chloride ion goes into this side of the blood, it will lead more reabsorption of potassium from the blood side into the cell. Yeah, that's pretty much what we can see. Guys,
Wait,
take over.
I have a
and
question.
just okay.
The aldosterone receptor, does it stimulate both the sodium and the potassium or just the sodium?
I feel it does both.
Okay.
It's just sodium, I think, not potassium.
Just sodium. Yeah. It stimulates sodium absorption, reabsorption.
And then it also removes the sodium out. Because when you see, annotate a minute. Because when you see, okay, it stimulates this sodium, the epithelial sodium channel, to get sodium inside this area. But then here it also stimulates the sodium getting out, but I think it also stimulates the potassium getting in to this principal cell. I don't know if you guys are getting it.
And
You're right.
I think the sodium will go in, the potassium will go in because of the gradient, like if the sodium is too much, it tends to exchange with
Yeah. Oh, okay. All right. This is confusing, but okay.
That you're right, actually, Divya. So if aldosterone stimulates the epithelial cells from the luminal side into the cell, they antipota actually, because it will sense that there's more sodium in the collective. So it will remove sodium outside to the blood. So through that gradient, sodium will come inside the cell. So the sparing diuretics, they work in this water because they spare the potassium. So, I think we are right.
Okay, wait. So there's the
Yeah.
amiloride is a example of potassium sparing.
No, it's an example of epithelial sodium channel inhibitor.
Amiloride.
Yeah.
Okay.
That is why it blocks the entry of sodium into the cell from the tubules. So this means that there'll be more sodium in the lumen of the tubula that will lead to natriuresis. Yeah, so the reduced entry of sodium into the cell also reduces the amount of sodium that can be exchanged for the potassium at the ATPase pump.
Okay.
That's what I know.
But
Yeah,
amiloride is also a potassium channel blocker.
Yeah. Oh, okay. All right.
See, potassium sparing diuretics are divided into either aldosterone antagonists and epithelial sodium channel inhibitors.
Yeah, but
So,
still, sodium, potassium pump, ATP. So it's still in a you guys are saying the same thing in short.
As in, like, as a diuretic, it inhibits that epithelial sodium channels, but when we come to like arrhythmias, it blocks now potassium channels. It has like two different, yeah.
Let me ask, for this spironolactone, it also acts in the collecting thingy, right?
Pardon?
I think spironolactone mostly works in the late distal tubule, because that's where aldosterone mostly works. And then for the collecting ducts, it's mostly the ADH.
Okay. Thank you.
Hey, we'll go back to wait. Who's sharing the screen? Other one. The other one. Above it, yeah, here. Potassium, they only work in distal tubule.
Guys, just go to the next one, the one with the side effect. Thank you.
Since physiology of it, call it a day. I don't know if you have a discussion in the evening. Disorders. Are we having discussion in the evening? Here.
So, do we have someone to take us through disorders?
I don't think people don't want to volunteer.
Because if we don't, then we don't think we'll have a session.
Yeah.
Which disorders are we doing?
Yeah. Acute kidney failure, like every disorders. The chronic kidney
AKI,
failure.
CKD, nephrotic syndrome. Yeah, I think this goes.
So say it was just acute kidney, chronic, nephrotic syndrome. Those three, yeah?
Yeah.
Okay, maybe I can try that.
Okay.
So maybe we can meet at what time? 5.
I don't know, guys, what time?
Yeah, 5. Because 8, we have the other one.
Okay.
Yeah.
When are we doing the diabetes then? Tomorrow?
Oh, we are doing diabetes as well today?
Wow. Diabetes was scheduled for Friday evening.
Yeah.
Can I ask, are we meeting on Saturday? Eh?
I don't mind tomorrow.
Yeah. What time though?